Thanks, Dr. Benoit and Dr. Weisi for your kind invitation. I already talked about percutaneous adductor tendon release for hallux valgus surgery, a biomechanical study, and Dr. Del Javier for Buenos Aires. Lateral release consists on anatomy of the adductor muscle with or without the detachment of other anatomical structures. It's commonly used for soft tissue corrections. So there are some questions that need to be answered. Which structure should be released? Which ones not? There are some things about concern, correction power, congruency, etc. And there is generalized confusion of the anatomical terminology. So there are two percutaneous techniques published. The first one is the isolated release of adductor tendon, and the second one is the extended release, when we can add the detachment of the suspensory sesamoid ligament. What did we know previously? The indication, it can be indicated in mild to severe hallux valgus in cases of incongruency. There are some clinical maneuvers to decide whether we need or not these techniques. And as I told you before, there's some confusion about the anatomical structures. This is an interesting study we published last year with Miki Dalmau. So the question was, what do the surgeons think they are releasing? There's some confusion about the words they use, or even the structure they think they are releasing on the published studies. What did we not know previously? What structures should be released, which ones not, how to make it percutaneous and safe, and the correction power of this technique. We decided to split this study in two. The first one was to analyze biomechanical the valgus correction power, and the other one was to know if this procedure was safe and secure of an isolated percutaneous adductor tendon release that was made on the first web space. We used 11 cadaveric feet, and they had moderate hallux valgus. The technique was performed by an experienced MIS surgeon. We made the X-rays with a special weight-bearing device that was published in 2006, and all the specimens had the key maneuver positive. So it was a passive correction possible. So this is the technique for this cadaveric study. We use a 4mm portal on the first web space portal, at the level of first metatarsophalangeal joint. The blade is advanced with an orientation of 60 degrees until a quarter of the blade is inside the joint. And at this point, the blade is turned 90 degrees to the lateral aspect of the joint to face the adductor tendon, while the first toe is driven into varus. We make the angular correction angles, and the results were compared with each other. These are mainly the X-rays that we have and the measurements. These are some of the results. This surgery predicts angular correction, so we can, if we do this surgery properly, we can know how we can correct the hallux valgus angle, and it confirmed the correction power. Other results of this study: no sesamoid reduction was seen. There was no statistically significant differences when assessing the first metatarsal and phalanx rotation before and after doing this isolated release. The conclusion is that this procedure provides powerful and quantifiable correction of hallux valgus deformity and can be used accurately percutaneously. This is the result of the safety study. On 100%, we have done the complete section of oblique portion of adductor tendon, and in 4 cases, 36.4%, we did the complete adductor tendon release and the lateral collateral ligament release. Some of the other results of the safety study, probably due to overpenetration of the blade, cases 1 or specimens 1 and 4 had MTP arthritis, and perhaps due to this issue, the technique was difficult, resulting in excessive and imprecise lateral release. In these 2 cases, we've seen a complete release of FHL and the adductor tendon detachment. This is an interesting study that is not published yet. We have seen in these 11 cadavers and another 39 feet and radiolucent image that we name triangle sign. In 100%, we see that the observers saw a triangle, a radiolucent image, and in 75% a triangle image. This is the technique in a clinical aspect. Here we can even measure the angles where we have to enter with our knife. This is the last step when we really release the adductor tendon and the lateroplantar capsule. This is another clinical sign to see if we have done this properly. This we call it waterfall sign. If we release the capsuloplantar properly, we can say how this water falls from the medial side. As a discussion, while it is not known exactly which anatomical structure should be released, some authors recommend the release of the adductor tendon predominantly. The lateral release, the adductor tendon release, seems more secure than other open lateral release techniques. And there could, for Jamin and collaborators, there could be a beneficial effect of sectioning the suspensory ligament in all cases of hallux valgus, and a probable efficacy of an added adductor hallucis tendon transection in a moderate to severe. What have we learned recently? The applied anatomy, what we are sectioning in terms of the adductor tendon release. This is a safe and efficient procedure. Biomechanically, we just now know what happens, and there are some radiological and clinical guiding signs. Thanks, Miki, for this anatomical dissection. Here we can see the oblique head of the adductor muscle, that is our objective when releasing the adductor tendon, and the other anatomical structures. What don't we know yet? Which structures we should release from soft tissue as a complementary procedure to osteotomies, which ones don't? If there are clinical differences between sectioning the adductor tendon, or even adding the lateral collateral ligament, or even sesamoid suspensory ligament, or the adductor. We don't have this information yet. And as a conclusion of the talk, these studies show that adductor tendon release is powerful, performing isodeltically, and safe to correct the hallux valgus, the valgus metatarsophalangeal joint. It seems that we should not continue with extra lateral release if we have correctly done the adductor tendon release. Thank you very much.